Welcome, everyone. Thanks for joining. My name is Marshall Bangs. I am Neurosom's Investor Relations Specialist. I'll be moderating today's webinar. Just wanted to thank everyone for joining today. Today's webinar will be introducing Neurosom, the new medical device company created to bring our advanced sleep assessment and therapy products into medical use in both the clinical setting and in the patient's home. Today, we'll get started off by Dawn Tucker, Neurosom's CEO, speaking on the link between poor sleep and health outcomes and on the development of the WISP technology that stimulates sleep. With that, I'm going to hand it off to Dawn, who is our first speaker.
Great. Thanks, Marshall. What I'd like to do is to give an overview of our seed round that we're raising on the Red Crow platform. The goal is to launch our medical device company, but particularly to complete a clinical trial for treating insomnia. And I'll mention that we also have a first round of $500,000 raise, in which our goal is to launch this clinical trial. So we've actually discounted with heavy bonuses on our stock for this first round. And I see on the platform things are already moving in that direction. Let me give a little history and then the focus of what we're doing with this seed round. So for many years, Neurosom scientists have been working to bring high-performance computing and artificial intelligence to understanding the human brain. And in this work, we've learned that high-density electroencephalography, EEG, is a particularly important technique. This work led us to develop a commercial company for high-density EEG, which we started back in the 90s with our first commercial outfit, which was Electrical Geodesics Incorporated. So we were successful not only in the science development, but in the technology of bringing advanced computing and AI to deciphering the complex activity of the brain. With our initial commercial success, we eventually sold to Philips, allowing us to bring high density to medical practice. And it allowed us to learn quite a bit about medical device companies, how they work, how they deal with regulation. With that event, we established the Brain Electrophysiology Laboratory Company. It was really the next generation of advanced technologies, particularly with source localizing the electrical activity of the brain. And I'll explain in a minute why that became important to our next step, which is Neurosom. This is the company we're now bringing to the Red Crow platform. The key element of this next step was a discovery we made with high-density EEG. We looked at the slow oscillations of deep sleep. So sleep has multiple stages, and the deepest stage of sleep involves these large oscillations across the surface of the head. And they're very large and global, but if you look at the electrical field pattern, you see there's negativity in the front, positivity in the back. We know that the brain sources are dipolar. They produce a negative field and a positive field simultaneously, and where they cross is likely to be the source. So we developed our advanced source localization, mathematical models of how electricity travels through the brain. And indeed, when we constructed a mathematical model of the individual's head, that electrical field pattern was fairly constant, and the source, the generator that could explain this field pattern, was deep in the middle of the brain, in fact, in the limbic system. Now, this is important for several reasons. One, we know that deep sleep is important to emotion. The impairment from insomnia can involve anxiety, depression, other emotional disruption. And we know, in fact, if we take healthy people, deprive them of a good night's sleep, the next day their anxiety is increased. So these deep limbic areas are critical to emotional mood and stability. They're also critical to memory. That is another key aspect of losing sleep. Particularly as you get older, you can't afford to lose much sleep if you want to keep your memory intact as an older person. So in fact, this led to our project on mild cognitive impairment for the National Institute of Aging. So it may seem esoteric to localize these brain waves, but seeing the limbic source was actually very instructive for understanding why deep sleep is so critical to good health and psychological functioning. There's another reason why it was useful. Once we knew where the sources of these slow oscillations are, we could use our computational modeling to target them and not require the entire array of 280 electrodes. Rather, we could use a few electrodes. So here in the front, we're showing sources, red electrodes, and the back, we're showing sinks. And in fact, the best sinks were on the neck, going through the big hole in the skull where the spine enters. With those few electrodes, we could effectively target these deep limbic sources at the base of the hemisphere. So the basic science taught us a couple of things. It taught us the capability of localizing the activity, but also the capability of targeting it with just a few electrodes. So at this point, we are able to bring Neurosom to market, not only with the high density EEG and the advanced mathematical source localization of the activity in the brain, but to also bring an easy to use home sleep system with just a few electrodes and battery powered to treat the brain, to actually augment the process of deep sleep. Let me finally emphasize that the science is key, and we're very excited about it, but that's not the only point. Part of what we're bringing to market with Neurosom is our team of very skilled personnel at many aspects of the business as well as the science. And in that for that question, I'm going to turn the next talk over to Viral Sheth, who will outline our business operations and the strategy for bringing Neurosom to market.
Our mission at Neurosom is simple yet profound: better sleep, better mind, better you. While we see the impact of our sleep therapy and sleep assessment very broad, that cuts across many brain disorders, we've identified two major segments: insomnia and cognitive decline. Based on the market size, unmet need, and growing scientific evidence, over 10% of the world's population suffer from long-term insomnia, and 50 million fight against cognitive decline every single day. The market for sleep health tech is really big, over 14 billion and growing to well over 20 billion by 2030. In particular, insomnia and cognitive therapy, cognitive decline therapies are projected to grow massively over the next several years, from 4.3 billion to 6 billion in 2030 for insomnia market, and from 4 billion to well over 15 billion for cognitive decline market by 2030. And by capturing this growth, Neurosom plans to serve 75,000 people annually by 2030. Our approach to capturing this growth is twofold. First, through direct sales to key opinion leaders in sleep medicine at large academic medical centers. These centers are directly aligned with our vision and our strategy for personalized care with in-clinic assessment and at-home therapy. And we've already started to make some inroads with these KOLs, which our Chief Innovation Officer, Dr. Justin Nichols, will highlight in his presentation today. Our second approach is to deploy a specialized regional sales force to maximize market penetration in high-density areas across over 2,000 American Academy of Sleep Medicine accredited sleep centers, followed by our focus in Europe and Asia. We also plan to form strategic partnerships with global suppliers of diagnostic and therapy devices, which will actually play a crucial role in scaling our operations and sales channels effectively in key geographies. And once we have FDA approval for our products, and we establish manufacturing at scale, we'll be selling our sleep therapy, particularly as a combination of upfront device cost and inexpensive monthly subscription model. Now let's look at some of our unique value proposition. While a number of companies have introduced devices for improving sleep, including sound or auditory stimulation that may improve relaxation at bedtime, they have largely followed the trend of introducing these devices directly to consumers rather than focusing on clinical trials and incorporating it as a medical device. On the other hand, we have a stringent quality management system already in place, and our upcoming FDA trials emphasize our commitment to regulatory compliance, safety, and scientific validation. Neurosom stands alone in its unique combination of HD-EEG, as Don mentioned, and targeted brain stimulation, offering personalized, effective solution for various sleep therapy. And this is backed by our patents. Our solutions are designed for both in clinic and at-home assessment, providing ease of access for patients and versatility. Moreover, it's personalized and adaptable to each user's sleep cycle. Our financial projections are actually quite promising. By 2030, we project substantial revenue growth from both our insomnia and cognitive decline market segments. We expect to clock well over $275 million in combined revenue annually by 2030. Again, to achieve these goals, we're seeking an investment of $5 million on Red Crow platform. And this funding, like Don mentioned, will help us launch our FDA trial for insomnia and help bring our advanced solution to the markets quicker. And for a limited time, we're offering a special bonus share option to early investors, enhancing the potential on return on investment. And it's worth noting, like Don mentioned, the core founding team and the executive team brings successful track record in delivering a return on investment, having built a thriving neurology medical device company from ground up, which was later acquired by Philips. So again, I invite you to join us on this exciting journey. Together, we can have a significant impact on public health worldwide. And for more information about how you could support Neurosom, please feel free to visit Red Crow website, where you will find a lot more details about the company, our business plan, and limited time special share bonus. With that, I'll pass it over to Dr. Fan Liu, our Chief Science Officer, to talk about clinical trials efforts.
Thank you, Viral. Okay, so I'll provide a high-level introduction to our clinical trial, or plans for our clinical trial. So the trial is intended to assess whether WISP can be used to treat insomnia. So as Don reviewed earlier, insomnia is a disorder that affects sleep. And these are the major symptoms. Patients report difficulty falling asleep, staying asleep once they get to sleep, and then waking from sleep earlier than desired. And it affects the consequences of poor sleep affects daytime function and increases symptoms of anxiety. And the health implication, as already alluded to, are functions associated with aging, and this is a very active area of ongoing research, as well as the vicious cycle that it sets up with symptoms of both anxiety and depression. So the trial, the basis of the trial, is really centered around what Don reviewed earlier. Here, let me show you the changes to sleep that we can affect by using transcranial electrical stimulation. And this is a figure from the published study that Don showed. Based on the ability to target the generators of slow oscillations, we were able to basically replicate what previous research has shown, that using TES, you can enhance slow wave sleep or deep sleep, also known as N3 sleep. So this graph here shows the different stages of sleep, N3 being slow wave sleep. So in this study, we targeted those slow wave generating structures. And as participants enter N3 sleep, we provide very low level current stimulation, actually half the level that prior research has shown. So about half of a milliamp. And we show that it actually only affects the slow stage of sleep, deep sleep. So here you can see blue is the actual stimulation and green is sham. There's a significant increase in time spent in slow wave sleep. So based on those results with high definition EEG, we built the sleep wisp, the headband, for in-home use, and placed electrodes only in those positions that we verified with the previous study. And so this is a replication study here using the WISP TES and in an in-home environment. The previous study was done in lab. And in this one, being in home, the system has to also automatically detect when a participant is in or entering deep sleep. And so here we fully replicated the previous findings using the WISP and the machine learning approach to recognizing the stages of sleep and then applying the appropriate current. This is a clinical trial with healthy young adults that is actually registered on clinicaltrials.gov. So this forms the basis of our plan for the clinical trial with insomnia. In the insomnia trial, we'll also add the practice of good sleep hygiene. This is really important to address the front end, the falling asleep, the latency to sleep onset. So people with insomnia have a hard time falling asleep when they get into bed. One of the best approaches to dealing with that is cognitive behavioral therapy for insomnia. A big component of that is good sleep practices. So we're going to couple that with our TES approach to facilitate sleep onset and keep people in deep sleep, the stage of sleep that is associated with feeling refreshed when you wake. A little bit about our clinical trial experience. So we've already had Q submissions. This is a special program that the FDA has for getting feedback on clinical trial design, as well as the medical device, or the device that's used in these clinical trials. We've had actually 2 separate submissions for this to get feedback on different aspects of it. We also have experience with clinical trial conduct and management according to the FDA's BMO program. This is a really important aspect of a clinical trial, because this is how the FDA will review the evidence. So you can present the evidence and the results, but ultimately it has to, the whole conduct will be examined. We have a good program in place that's compliant with BMO standards. And finally, we also have experience with the 510K clearance process for medical devices. In this case, it would be a de novo 510K, meaning that there are no previous predicates that has the intended use that we will be shooting for. So with that, let me then turn the presentation over to Dr. Nichols.
Thank you, Fawn. I am very excited to talk with you all today. My name is Justin Nichols. I'm the Chief Innovation Officer with Neurosom, and I'm going to talk about how we tie kind of the big picture together. So we have a legacy of developing high definition HD-EEG. We've worked with elite institutions all over the world and using this technology to detect really hard to detect signals in the brain. And we've found that elite institutions like the National Institutes of Health, Mount Sinai, Northwestern, Children's National, multiple military groups, they are familiar with our background. They know a bit about Neurosom and what we're doing with our sleep WISP, and they've approached us, and they're integrating some of our capabilities into their projects, some exciting projects. So, as you know, we have a platform for high definition EEG. It's a comfortable high definition head web, and it's much better than traditional EEG. It's faster to apply, and not only that, it's much more accurate in being able to pinpoint the subtle activity that's in the brain. And you can see here kind of a comparison between a traditional EEG system, and then there's so much more data with 280 channels. So if you're trying to look at something, you may miss it with traditional systems. But how to tie all of that together? And this is, I think, what is so exciting, is we've developed a vision, and this vision incorporates high definition EEG with a component in the home. And nobody else does this. Nobody else can do the high definition EEG and then control all of this data in a data informatics platform like we do. We actually solved this and made it turnkey with our Flow software platform. And so tying these together, it's very exciting, because there are a lot more capabilities in having high definition plus the capacity to look at sleep in the home and to treat sleep. And you can imagine all types of therapies, all types of clinical trials. If there's poor sleep, it's going to impact results. And so with this platform, I think we're going to see improvement across the board. And so we've kind of extended our high definition EEG portfolio into this ecosystem. And we have a flagship HD-EEG ecosystem extended into the home with WISP. And on top of that, we're able to look in the brain, look at the waveforms, process data, we've created a software platform for data analysis and extraction that's extremely user-friendly and quick. There are options out there that are very expensive that just aren't intuitive. And we've solved many of those problems and received great feedback on the entire workflow. So it's a lot of data to handle, but we've made that a lot easier to do. So we've got this entire ecosystem with high definition EEG. We've got WISP, and we've got this platform for being, no matter what your intervention is or your research project is, being able to map what the brain is doing before, apply the therapy so that you can guide and better titrate whatever that therapy is. For example, in this we have deep brain stimulation. There are a few groups that we work with that have used deep brain stimulation for Parkinson's, deep brain stimulation for treatment of depression, which is emerging. And in order to tune this to the individual, you need to understand what the brain is doing and how it's changing in response to your treatment. High definition sets the baseline for that, but then you need to monitor sleep. Sleep is crucial for plasticity to happen for any intervention. So we've tied this together into a platform that I think is very scalable and can be applied to lots of intervention. And these groups, Mount Sinai, a few months ago, I handed them the first WISP device, and they were super excited. I've worked with them for a number of years, almost a decade, and they were super excited to see this kind of transformation, see the evolution over time. We're frequently at the National Institutes of Health. They have an amazing project looking at pediatrics and changes in sleep, and they're trying to tackle and extract what can happen in the brain and in these kids. Children's National has an interesting project also looking at kids. Northwestern Medical School here with Dr. Chung has a project on individuals with Down syndrome that we're very excited about. The big picture for all of these groups is they know our legacy and they put continued trust into us for this next step with our ecosystem. And so I'm excited to see that they're excited about our vision moving forward. And with that, I will hand it back to Marshall.
Right, thank you, speakers. That was great. Now I would like to open up the floor to any questions that anyone has. If you would just like to drop those into the chat box. And I want to thank everyone for attending today. All right, looks like our first question, maybe this is a good one for Fawn, is how long is the FDA trial process expected to take?
That's a tougher question to answer in specifics. So the trial itself is dependent on multiple factors. First, getting the funding to start, as well as the nature of the protocol that we imagine could take the protocol itself to run anywhere between 6 months to a year, depending on a couple of factors. We know about the number of participants that we need to enroll and the design, of course, but the logistics of running it, they're unpredictable things. And then, of course, after that, what will happen is then there's the whole FDA review process of the evidence. That's also undetermined, meaning, we don't know how many cycles we'd have to go through. Once an application for clearance consideration goes into the FDA, it takes about 90 days for the FDA to get back to the applicant. And that's just for one round. So a realistic timeline would probably be around a year and a half, 2 years, optimistically. Don, I don't, yeah, I don't know if you want to chime in on that.
No, that's good. That makes sense.
All right. Thank you, Fawn. Looks like our next question is a bit of a multi-parter. I might bring this first one to Dawn, asking what the theoretical or conceptual framework of the treatment is.
Yeah, the core idea is that once we know how the brain is generating deep sleep, and we see these large discharges of limbic regions that are synchronizing it, then we know how to treat it. We just synchronize those from external electrical currents. It's kind of impressive that the brain doesn't know the difference between its own electricity, which helps to synchronize, and external applied currents. That's an amazing window into being able to manipulate the brain. And that's what we've done with our deep sleep therapy. We synchronize those slow oscillations and cause them to last longer. And as a result, the person gets a better night of restful deep sleep.
All right, thank you, Dawn. And I'm going to bring this next question back to Fawn, asking what is the proven effectiveness of the product and if there is any clinical studies or research data currently?
Yeah. So enhancement of deep sleep in healthy adults has been shown not only by us, but by other groups. Actually, our work was inspired by previous studies showing that. And we've replicated that in 2 studies. One is with the high definition approach, where we were validating that we are hitting the targets, the generators of slow waves in slow wave sleep. We did that in lab with basically a lab system, a high definition lab system. And then we replicated that with this specific device, the Sleep Wisp, as we designed it based on the previous studies. And we replicated the full effect. Actually, was a little bit stronger in effect when we did this in the home, and we showed that. And now the challenge is to show that it works for the treatment of insomnia. That really is our main focus for this clinical trial.
That's right. Let me just add that insomnia is going to be more difficult than the healthy adults. So our most recent replication study is giving significant results now, and we've registered that as a clinical trial, but it's with healthy adults.
That's right.
People with insomnia often have anxiety, depression, other issues. So we think that's going to be a bigger challenge, and we're being very careful about designing that trial to test that question. Can we really bring it to clinical practice?
All right, thank you. And I'm going to bring this one to Dawn, asking how does the project manage intellectual property?
Good question. We have a long history of careful patent application. So in fact, right now I hold the record from the University of Oregon faculty for successful patents. And they appointed me to the American Academy of Inventors as a result. We have a great, it's not just me and our scientists, we have a great patent attorney team that helps us to formulate what is defensible of new inventions that we develop. So right now, Neurosom has 2 key patents. And we have two more on the way at the Brain Electrophysiology Laboratory that I think will be very relevant and that we plan to license to Neurosom this year as we get products that will be relevant to Neurosom's goal. So it is a key issue. The patents we have cover the design of the geodesic head web, the new high density system, but they also cover what's probably more important, our electrical stimulation technology, how we apply the external currents in order to manipulate the brain's own currents. So I think we have what is a fundamental patent, and that's now licensed to Neurosom and part of the Neurosom formula that'll give us protection as we go to these clinical trials.
All right, thanks. And I'm going to bring the next question to either Viral or maybe Justin. How does the project adapt to technological advancements and market trends?
Yeah, we've done careful analysis on some of the ongoing competitors as I presented in sort of how we've reviewed and how we could differentiate ourselves from the competition. And one of the stronger suite we believe that Neurosom brings to the table is our focus on quality management system and bringing it as an FDA-approved medical device. And we'll continue to monitor, particularly from a science aspect in terms of the trends that happen in the field. We continue to attend a bunch of scientific conferences to keep ourselves abreast of the developments in the field. In fact, Justin is going to be at the sleep conference in the next couple of weeks. And so that's one of the ways that we continue to monitor the ongoing innovation as well.
Great. And next question I might bring to Fawn is asking if we have identified a partner for the FDA study.
No, we have not. We have started conversations with potential collaborators on this. Nothing is solid yet.
All right, thank you, Fawn. And I might bring this next question to you as well. Question asking about the difference in the increase in REM sleep between the home trial and the clinical trial, and asking about the difference between home and lab results with the WISP.
Great, yeah. Really good eye, Russ. In fact, yes, when in the first study, we noted that too, although it was not statistically significant. It seemed to increase it, but that's the sort of the nature of these studies is they have to be replicated. And so in the second study, we did not see that. And so it looks like that could be just random fluctuations in the variability. And it just sort of leaned towards TES for REM in the first study, but we did not see in the second. So this is something that we definitely have to keep our eyes on to see if TES, which is just the way we designed it, is only targeting the deep sleep, is changing any of the other sleep stages or the architecture of sleep. So far, we don't see that.
Yes. Hi, this is Russ. Can you hear me?
Yes.
Yep.
It also looked like the earlier stages of slow wave sleep were increased in the home study, but not the lab study. And I guess that's another area of possible difference.
Yep.
No, that's right. And we think the home replication is particularly important because it's automatic. So in the lab study, we did what is typical is we had technicians observing the EEG in order to deliver the electrical stimulation at the right time. In other words, when they had been in N2 sleep for 4 minutes, that's about the right time for them to shift to N3. So we made it easy on ourselves of using the electrical stimulation when the brain is already to go into N3 sleep. And then we showed we could enhance it. But
see.
at home, we can't have a technician monitoring each person. So this is where we brought our machine learning, the AI classification of the EEG that we've worked on for so many years. And here, the AI, the machine learning, is able to detect the sleep stages automatically and then turn on the stimulation. So we had validated this pretty well in the laboratory, and so we were confident it will work at home. But those second replication results that Fawn showed were fully automated. It was a fully automated classification of the sleep by the bedside AI. The little NVIDIA chip is doing this massive computing right at the bedside. And then we were able to deliver the electric current right at the appropriate time. So there's key technical differences, but I think from a practical point of view, we want this to be cheap and affordable at home. And that's our goal with this trial. It'll all be done in the home under direction by AI.
Yes, thank you.
All right, thank you. And for the next question, I might take this back to Dawn, asking if there is any investigation into the effects of sleep inertia.
Very good question. This has become an important topic in our military studies, where we're trying to improve naps. Many times, people in military operational environments can't get a good night's sleep. They can only get a short nap. And so our project with the U.S. Army Aeromedical Research Laboratory now is to work with helicopter pilots that get short naps. Can we improve their deep sleep during the short nap and then improve their performance? One of the problems that does happen is sleep inertia. People wake up after a nap, but they might not be fully awake. And truth is, we don't have a solution for that yet. Our goal is just to make the deep sleep better right now, because we can do that. But we're going to have to be paying attention to sleep inertia and maybe looking at some ways we can snap people awake, quickly when it's time to perform. But so far, that's not in our roadmap.
Right. Might bring this next question to Fawn, asking, have you considered the long-term effects or consequences of slow wave enhancement, saying that many other commercially available devices have been pulled off of the market recently?
Yeah, so of course, we're not aware, or I'm not aware of any of the long-term effects, because this is, again, a relatively new technology, and it's only been used really in research lab for slow wave sleep. I don't know of any other commercial devices that, aside maybe from the auditory Philips, but that's not a clinical device, and nor TES. On long-term, any long-term side effects of slow wave sleep enhancement. Yeah, so the Dream and the Philips Smart Sleep, that one, the Philip, I think, is an auditory one, and the Dream, again, I think both of those were not Philips is auditory. Dream, I don't know if they were targeting slow wave sleep per se, and
so we know the Philips Smart Sleep was taken off the market because Philips had to withdraw all of its sleep products under an FDA consensus decree. They made some quality system problems with their CPAP. So the regulatory people decided to pull all of the things off the market. Dream 2 went through a pivot of their business model, which is the main reason they quit selling that market. So we try to follow this very carefully and don't know of any long-term adverse effects. Um, but this is part of our clinical trial monitoring. We're using the machine learning to characterize each person's sleep stages so that we can look for any adverse trends. So the first one, we want to be sure we're not damaging the other stages of sleep, like REM, for example. We want to be sure the full sleep architecture is good. And then as we look over time, we want to monitor over time, both with the sleep measures, but also with our clinical evaluation, questionnaires on sleep quality to determine that the effects are beneficial and not problematic. This is a key part of the clinical trial.
Yeah, and we don't again, don't know what the long-term effects, the negative long-term effects can be are because again, this is a relatively new approach to sleep, and I don't think anybody's has long-term data to show otherwise. We think it's relatively free of side effects, but like Don said, we have to be very careful in our clinical trials to see any adverse events. This is part of the study. But
That's right, and
all I can say.
I'll add that our clinical experts, so we have sleep neurologists who confer with us on the research studies and on the clinical trial design. So Dr. Ruth Benka, former president of the American Association for Sleep Medicine, is working with us as a collaborator on our trial with older people with mild cognitive impairment. Justin mentioned several of other collaborators, Phyllis Z at Northwestern University, Ashura Buckley at NIMH. And none of them are that concerned with enhancing N3 because particularly in adults, N3 declines. And it's the loss of N3 or the deep sleep that seems to lead to memory impairment. So it is an important issue to monitor for the long-term effects, but we're pretty confident, and our medical advisors are pretty confident that there should not be impairment of bringing deep sleep back to a young person's level. That's kind of the goal.
All right, thank you, Don and Fawn. I'd like to ask if there's any more questions anyone wants to ask in the chat box. All right, then. I would like to thank everyone for coming out today and participating in the webinar.